So when I had to choose these cases, it was a little bit challenging because in my experience, spine surgeons more than anyone else know their imaging. They know what they're looking at. They know it probably better than the radiologist. For me to find something that was new and different and hopefully helpful was really tough. But I was inspired by a tweet that I saw posted a couple weeks ago, not a couple weeks ago, a couple days ago, from Michael Galgano. So he's a member of our virtual spine community. And he posted one of his cases and posed a question, tagged virtual spine, and immediately he got all these responses. So answers and references, more questions, started this great discussion, which to me in itself is absolutely amazing. We're brand new. We're already all coming together. We're helping each other. We're learning from each other. So that I really, really liked this a lot. And he posed a great question as well, a very difficult question. So this is what he said. He had this patient who had had cervical spine surgery, now had worsening symptoms. And so he came back in and they got a thoracic spine MRI. Now I've blown up. Can everybody see my arrow okay there? Yeah, arrow?
Yeah, we see your mouse, yep.
Yes, mouse, okay, good. Sagittal T2 weighted image, axial T2 weighted image, blown up. It's not great quality the way I've done it here, but you can definitely see there's an abnormality. Spinal cord coming forward to the ventral aspect of the canal and then back, so abnormal course. Spinal cord very thin here where it's coming ventrally. Here on the axial T2 weighted image, spinal canal, you can see the cord at the very front of the canal, way more ventral than it should be in the middle. So we know there's something wrong here. And he already had an idea of what he thought it was going to be. So he asked, tips for differentiating arachnoid web or arachnoid cyst from spinal cord herniation. Great, great question, a very difficult question. And you can see down here, our own Dr. Baj immediately answered with one of his papers because he already knows all about this. But like I said, there were a lot more questions, and even unrelated to this post, this question has been posed a lot in like radiology circles as well. It's a very difficult one. And the reason it's important is because these patients, whether they have arachnoid web or they have spinal cord herniation, can almost all be helped by surgery, right? Other hosts, yes, true? Almost all of them can be helped by surgery. The problem is diagnosis is often delayed. The symptoms are usually gradual in onset, very nonspecific, and people, because this is rare, don't know to look for it. So this inspired the very loose theme for my cases today, okay? All right, first case. This is a very unfortunate 40-year-old woman, widely metastatic breast cancer. I'm gonna go through these images for people, a lot of the trainees, a lot of people in the audience who don't know a lot about imaging. I'm gonna try to tell you some of the sequences and some of the things we look for as radiologists. For a lot of you, this will be basic, some of you it'll be brand new, and so hopefully some of it will help someone. This is a sagittal T1 weighted image. We look at T1 weighted images in the spine for two things primarily. We're looking at the bone marrow, and we're looking at things that are defined by fat. So this woman's symptoms, all I got was back pain and radiculopathy, despite her cancer. So what I'm thinking is, okay, maybe she has a pathologic fracture, but radiculopathy, maybe it's something else. Whole spine was imaged, but I thought, okay, I'm gonna start in the lumbar spine because that's where I'm gonna look for radiculopathy first. Sagittal T1, we look at the neuroforamen from the side. So this is a nerve root. This is the fat around the nerve root. And this is how we look for nerve root compression. The less fat there is, the more compressed the nerve is in the foramen. So coming down, looking nerve root fat, you can see here at this level, big gray blob. Obviously that is not a normal foramen, not a normal nerve root. This was the only place in her entire spine that actually had epidural extension of disease. Here's an axial T2 weighted image. You can see there's abnormal soft tissue intensity in this foramen. So like you guys, when you pull out a big juicy disc or a big tumor, and it's very satisfying. When we have something that we say, okay, this finding exactly goes along with the person's symptoms, it's very satisfying. So I was very excited that I found her pain. But then I had to read the rest of the spine. So I went to the thoracic spine, and this is what I found there. So I think you all know what this is, hosts, but I would like you to tell me why it is what it is. There are at least three things in these images that let you know exactly what it is and why. I can give you the sequences if you want. Sagittal T2, blown up sagittal T2, and axial T2. Anybody want to take this one?
Yeah, I can say something quick here. I'll let the others, the other colleagues comment on what to do or not do. But since we do have a lot of students and residents and others here as far as the participants, I think this highlights something very important. The neurological exam is so important. A lot of times patients come in with an MRI of the lumbar spine, thinking that the problem is focal, in the lower back. But a full and thorough neurological exam with testing the reflexes, testing for myelopathy can lead you to potentially a different diagnosis. And a lot of times thoracic and cervical lesions are not picked up and underdiagnosed because we're focusing in on the image that the patient comes with. So I think this is a great case, but I'll see if John Shen or Coy want to jump in here.
Yeah, I think, Ali, that's a great point. And I think that you just have to be careful because I think we're always thinking about myelopathy, but a lot of these patients also present with Brown-Séquard syndrome. And so I think a careful neurological exam is really important.
Okay, you guys are too slow. I have to take this case myself. Yeah, can I take this? Oh, Coy.
Hey, Wendy. Yeah, so it looks, like an arachnoid cyst. That would be, my bet. You sort of see.
You can't say what until you say why.
Well, you see on the sagittal, the rostral and pelvic holes of the cyst wall. You see it's eccentric to one side. I'm not sure if that makes it more, one versus the other. And I don't know, maybe you can comment on the flow voids as well.
Yeah, okay, that's excellent. So I'm trying to see it. Like I said, these cases, you all know what they are, but the radiologist's job is to kind of explain from the images why they are what they are. So yes, you're right. This is an arachnoid cyst. So you talked about the wall. This is an easy one. Most are not this easy. This one, you can see the wall going all the way around. And you mentioned the flow voids, and that's excellent. This is a young patient, widely patent canal. When you're looking at a spinal canal, there are two things that live in the spinal canal that you're able to see, the cord and the CSF. That's all you should be seeing. So all these little lines that are gray, if the audience can see this is flow artifact. Our imaging is advanced now, and we've actually been able to but I'm echoing a little bit. Is anybody else hearing that echo? Anyway, you can see, but we can bring this flow artifact back if we need to do problem solving. So you can see flow artifact below the cyst, above the cyst, not within the cyst. So we know this is a mass pushing the spinal cord forward. This is a little bit like that first case, but not exactly. Pushing it forward very smoothly. On our axial, same thing, CSF intensity, flattening the cord, a little bit of CSF ventral though that we can see. All right, let me show you this very quickly. This is how I learned about spinal cysts. There are three types: extradural, perineural or Tarloff, and intradural arachnoid cysts. This is an intradural arachnoid cyst. You know it's not an extradural process because that would look more like a meningioma coming in with an angle like this rather than an acute angle like this that we know is within the dura. All right. But like I said, it's not always so clear what these are. Sometimes you can't see the walls at all, even with high resolution imaging. Oftentimes arachnoid cysts are also open to the CSF. They're only partially closed. So in that case, myelography, I'm a big myelography fan. I know a lot of people don't like it these days. I think it solves all kinds of problems. So same thing, sagittal image, myelogram, you inject contrast, can do this right on the CT table so you can image immediately. Arachnoid cysts, even though they're walled off, will often fill with contrast, but they will fill at a differential rate. So if you catch it quickly, as in this case, you can see it's already starting to fill, but we can see the difference from what's around it. We know that there is a mass behind the spinal cord pushing it forward, okay? And that's your tip. Do your myelogram under CT to catch that fast filling on some of these arachnoid cysts. All right, next case. So similar but different. Let's let Dr. Baj take this one if he's paying attention. Otherwise, I'll take it.
All right. So it looks like you're showing a T2 MRI, a T2 sequence. Obviously what we can see here is one thing that I pay attention to a lot when I see a report or something that's a little bit suspicious, which is, I think you're showing the scalpel sign here, which is an indentation of the spinal cord and the thoracic spinal cord with a cyst right behind it, you know, the so-called spinal arachnoid web. I believe that's what this is.
Okay, excellent. Yeah, so this is similar but different. The last one was something behind the cord pushing it forward, right? This one is a little bit different. This one has a very focal abnormality in the cord caliber and cord direction. Flow artifacts behind, there's actually nothing behind the cord here. This is all CSF flow artifact. I'm sorry, I'm talking slowly, but I'm echoing to myself. Axial T2 image. Nothing should be within the canal except cord and CSF. This thing isn't real. This is flow artifact. That means there's no mass there. Cord is not being pushed forward. The cord is being pulled forward. So yes, as Dr. Bosch said, this is the arachnoid web with the scalpel sign. Now, one more thing on this one. I don't know if it's obvious. There was a little bit of T2 signal within the cord because it's being compressed from CSF flow within the cord. Just in case you weren't sure, here's a myelogram to show you again. Very homogeneous contrast column. There is no mass behind the cord here. There's no mass, there's no cyst, nothing. Axial myelogram image right here. No mass behind the cord. It's being pulled forward, not pushed forward. As you said, scalpel sign. This is, I guess, what a scalpel looks like. And this is what the cord looks like in this particular arachnoid web. Here's Dr. Bosch's paper. I'll post some of these links on Twitter when we're done so people can take a look at this. All right, what about this case? Maybe in the interest of time, I will take it since we got a little bit of a late start. How about that? This is a myelogram, sagittal. I injected the contrast under fluoro, took him to CT. So this is all contrast. This is the spinal cord. Abnormal course of the spinal cord coming ventrally. The cord is very narrowed at this point as well. Is this a scalpel sign? Or is it the smooth C sign that we saw from the arachnoid cyst? A little bit hard to tell. Here are our axial images. This thing is the cord up here in the front. Normal, homogeneous contrast. There is no mass behind the spinal cord in the canal. So it's not being pushed forward. It's being pulled forward by something. So is it an arachnoid web or spinal cord herniation? And this goes back to the original poster's question. I would say in this case, it's coming all the way up to the dura in the front. We don't see any CSF in front of it. One other big clue that I've found is helpful, although I haven't seen that many, the cord is rotated. Cord rotation generally only happens when it's being herniated through the dura. So in this case, I would say that. And I think Dr. Bosch told us it's important to know the difference between the web and the herniation ahead of time for your surgical planning, right? Yeah, okay. So here's a more blatant case. This one you wouldn't mistake for anything else. So cord, sagittal T2, cord coming forward, markedly narrowed, fast, gray flow artifact. There shouldn't be anything here but CSF, so we know that's flow artifact. Here's the axial, cord herniation, actually so much pulsation and deformation that it's going into the bone. So this one, no one would mistake. I won't go too much into the way this happens, but this is a very nice picture from one of my former partners, Matt Skalski, who's an MSK radiologist, showing how it pushes forward. It starts to herniate either ventrally or ventrolaterally, and then it starts to rotate, as I was saying on these images. This is actually from the literature. I had never heard of the nuclear trail sign before, but if you see this sclerotic irregularity in the end plate, they think this that might have been where there was a disc protrusion that incited the inflammation that started the entire process. So that was the answer to that question from Twitter. That was kind of fun, I think, to go through those and learn. This is a much more dramatic case. This is a case of ankylosing spondylitis. This case, very marked deformity, as you can see. Let me skip to the next one. This was in a matter of 3 years between these first two images and these two images. The pulsations and the ventral herniation of the cord really progressed. And what I wanted to ask you, if there was time, if this person is symptomatic, how would you treat someone like this? Or can you treat them?
Yeah, that is a very impressive MRI, Wendy, for sure. I mean, I think what I was going to say even before you showed this, these thoracic lesions, whether it's an arachnoid web or a cyst, I think the clinicians and the surgeons have to be very careful, because sometimes patients come in with, say, back pain, but these are high-risk surgeries, and often, we really want upper motor neuron signs, myelopathy, before we intervene surgically. A lot of arachnoid webs and arachnoid cysts are incidentally found, and if the patient only has very mild pain, we sometimes like to treat that non-operatively. I think the spinal cord herniations, or certainly cases like this where there is, obviously neural element, issues here, patients tend to be myelopathic, and those patients we're more eager to try to help surgically. Although these are very challenging. This is a very challenging operation for sure.
Okay. All right, well, let me move on. And you tell me, because we did get a late start and I don't know how much longer I should go. You tell me how much farther to keep going.
Sure, maybe we'll show one more case and then get Dr. Albert back on for the cervical. Is that okay?
Sure.
Great.
Then I'll show the rest another day.
Maybe
Okay,
do we have time for one quick question from the audience, Dr. Gibbs? One question was, can you speak about the role of contrasted MRI when you're working these up?
For the arachnoid.
For the arachnoid cyst.
It's a good idea, and that was going to come up in this case as well. It's always good to get contrast if you can, to make sure you're not dealing with a cystic tumor. If you have some little nodule of enhancement, I'm wondering, is that what they mean? I'm not sure.
Yeah.
You do want contrast to make sure you're not dealing with something else besides a normal, simple cyst.
Got it. And the second question was on the CT myelograms, when you're talking about monitoring the speed of the filling, just how fast are you talking about between the injection and when you're running your CT sequences?
So, if you do it under fluoro, it takes a few minutes to get the patient off the table, get them over to CT, get them in. Sometimes that can take up to like a half an hour. If you're worried about a fast, whether it's leaks or whether it's flow into a cyst like this, if you do it on the CT table, I basically inject the contrast. I get them in within, a minute, of less than a minute of contrast injection, get them scanned. So I can see immediately, even if it's very fast filling, what's going on.
Thank you.
Okay. All right. So this one, this was another tweet that was copied to Virtual Spine, that somebody asked me about this and how radiologists participate in treatment of some of these cases. And this was one that was referred to me by neurosurgery. So this is less of a guess and tell and more of a description of a procedure people might not know exists. So if you see these, you can refer them to us, to me. Sagittal T2 weighted image, sagittal post-contrast fat saturated image, axial post-contrast fat saturated image through the sacrum. So you can see here's the cauda equina down in the sacrum. There's something that looks like a cyst. It may have little loculations. We know it's been there a very long time because the bone is remodeled and the whole canal is expanded. We did the contrast, like we were just saying, to make sure this was not a cystic tumor. Here on the axial, we can see this is not a cystic tumor. These are nerve roots. These are little neural elements in the ventral aspect of the cyst and canal. So this is easy. This is a Tarlov cyst. So this is type 2. And so again, post-contrast axial T2. Here are the nerves right here in the corners, and this is CSF, and the same thing. Now this particular case, was an 18-year-old girl who had been a really active athlete. She started having very nonspecific, like low back pain and pelvic pain, and they had given her every kind of workup. It took her like a year to get worked up. She finally went to neurosurgery, and neurosurgery sent her to me and said, we can't find any other cause for her symptoms. Can you see if it's that Tarlov cyst? And I said, sure. So this is how we work these up. It's an interesting workup, and it has to do with the CSF spaces that we've discussed so far. So when we have Tarlov cysts, first we want to know if they are connected to the thecal sac by a large connection or by a very small connection that allows one-way flow by kind of a ball valve mechanism. Those are the ideal patients that I can treat. So like I said, MRI with contrast, make sure it's not a cystic tumor. Next, we do myelography. So this is under fluoro. And those people who say they don't like myelograms, look at this gorgeous, gorgeous picture. This is just beautiful. Anyway, so I'm watching it under fluoro. I inject my contrast. I'm watching to make sure the cyst is down here. I want to make sure there's no immediate filling of that cyst, because that means the connection is too wide. If I drain it, you can imagine if there's a wide connection, I'm going to suck the CSF out of the rest of the system and give them CSF hypotension. And even worse, if I put something in there like fibrin glue, it could get up into the thecal sac, cause an inflammatory reaction, arachnoiditis. They'd be way worse off than they were in the beginning. So I watch it under fluoro, take them to CT, do an immediate CT, make sure that thing doesn't fill. I have them do a delayed CT. They walk around for 2 hours, come back. Again, make sure it doesn't fill. Make sure this is only one-way, slow accumulation of CSF in this cyst. That makes them a good candidate for treatment. So again, what I do, I can aspirate that to relieve the pressure on the nerves that you saw in the front of the canal. And then I can inject fibrin glue or tissue. And what that is supposedly supposed to do is cause an inflammatory reaction around the wall of the cyst to hopefully block off that little connection to the thecal sac. If that doesn't work, they go to surgery if it's deemed necessary. So this is the pictures from my procedure, the same patient. On their stomach on the CT table, because this is all remodeled, the bone is so thin, this is only an 18 gauge needle I can put in here. There's actually another needle you can't see in this picture that's like a pressure valve, because if you try to suck out fluid without having something else to relieve the pressure, you can imagine it'd be difficult and be very painful. So this picture up here, I've sucked out all the fluid, and then through the same needle, I've injected fibrin glue, which will be reabsorbed by the body, but first, hopefully that inflammatory reaction, which will close up that little hole. And indeed for this patient, she was better within a couple days. I checked on her actually 2 years later, still doing great, never had another problem. I get maybe one of these a year, and actually I've been fortunate that every single one of them has been helped by this. So good procedure. Try it maybe before surgery as an option. It's minimally invasive. These people go home the same day, an hour later. So something to try, give it a shot before considering a full surgical procedure. Okay, this is my last point on this, Alex. I know you're getting ready to stop me here. This patient came in, neurosurgery sent me this patient, big Charlotte cyst pushing forward this S1 nerve. They said that the symptoms this patient is having are referable to that nerve. Can you try to drain this? This one I had to do on the CT table because fluoro wasn't available. So I injected my contrast. I'll just show you the axials quickly. Scanned them within a minute. Already you see filling of that Charlotte with contrast. That means there's a big connection. So this person was not a candidate for me to put in the fibrin. Did not want to get that fibrin up into the thecal sac or drain CSF out of their system and give them hypotension. So, oh, okay. So do you want me to stop there? Do you want me to stop there? You want Dr. Albert, is he here?
Yeah, but is that's the conclusion of that last case, correct?
Yeah, this is actually the next one.
Yeah, yeah. No, I think that's great, Wendy. I mean, these are very, especially that last case you showed, that's a very difficult pathology to treat. And I'm glad that you or some of your colleagues can help with these, because these are challenging. These are definitely the cysts, especially the sacral cysts. I think Griffin has a few questions for you while we get Dr. Albert to try to upload his talk. So if you want to stop
sharing my screen.
Yeah, and then we'll have Dr. Albert pull his slides up while we I mean, honestly, it always just all the cases that you showed demonstrate the important relationship between the spine surgeon, the neuroradiologist, going over cases, seeing what's the best image before the treatment is employed. Thank you very much for showing those cases.